Hi, everyone, and welcome to our Menopause Q&A panel. My name is Elise Boucher, and I will be your moderator for this discussion. I would like to take this time to introduce our panelists. Dr. Susan Domchek is a medical oncologist and the director of the Vassar Center for BRCA. Dr. Ann Steiner is the director and founder of the Menopause Clinic at the Dickens Center for Women, as well as a clinical professor of obstetrics and gynecology. Dr. Chrisandra Shufelt is the Associate Director of the Barbra Streisand Women's Heart Center and the Preventative and Rehabilitative Cardiac Center at the Schmidt Heart Institute, as well as the current sitting president of the North American Menopause Society. And finally, Dr. Amna Khan is the Associate Professor of Medicine, Section of Endocrinology, Diabetes, and Metabolism at the University of Pennsylvania and Philadelphia VAMC. Thank you so much for joining us. We have had an overwhelming response to this specific panel, and we have a number of questions that have come in. We are going to do our best to answer as many as we can. So this first question is a question that is for Dr. Domchek and Dr. Steiner. Is there an optimal age to undergo risk-reducing salpingo oophorectomy? And does the age differ depending on family history or genetic status? And when this constituent is referring to the word optimal, they mean in the sense of balancing risk reduction with minimizing long-term adverse effects of induced menopause.
It's a great question. And the various guidelines, including the National Comprehensive Cancer Center Network, guidelines for the European Society for Medical Oncology, have all tried to take this on. And currently, the guidelines suggest that for BRCA1 mutation carriers, that risk-reducing salpingo oophorectomy be performed between ages 35 and 40. And for BRCA2, risk reduction between 40 and 45. For other gene mutations, the timing is later. So I'm just going to focus on these two right now. But for things like RAD51C and D, it's between 45 and 50, for example. So why these ages? Well, we're trying to balance the risk for the development of ovarian cancer with the risk of early menopause, which, as you'll hear from the rest of the panelists, can involve bone loss, cardiac issues, as well as quality of life issues. So the risk of developing ovarian cancer prior to age 40 for a BRCA1 mutation is less than 3%. And for BRCA2, the risk of developing ovarian cancer prior to age 45 is again less than 3%. That's why these numbers are chosen. Obviously, the lived experience of cancer in your family, and if there's an early onset ovarian cancer, may impact those risks, but it is why it's important to have that discussion with your providers.
Dr. Steiner, anything that you would like to add to Dr. Domchek?
I really can't add anything to that. I think, like everything else, we have to weigh the risks and benefits of doing the procedure against the increased risk of a woman going into menopause at a very young age. And all of these recommendations, guidelines, are based on weighing those risks. So I think I would just defer to what Dr. Domchek said about this.
Excellent. Thank you. A very thorough answer. Dr. Khan, we had a number of questions coming in about bone density and osteoporosis. This particular constituent says, I'm 45 and having my ovaries removed this year. How often should I have my bone density checked?
So that's a great question. And I don't think we have any long-term data on how often the DEXA screening should be done in these earlier or premature menopause young females. However, from what we know from postmenopausal women who go through natural menopause, the current recommendation is to have the DEXA screening done every 2 years, just based on the BMD changes having a lag, because the best BMD changes are seen at about 18 to 24 months. That being said, we also know from the limited data that the sudden loss of estrogen will lead to a rapid increase in bone resorption, and there will be a rapid decline in bone density. And a few prospective trials looking at the bone density decline going maximum up to 2 years have shown that there is rapid bone density decline. So to answer this question, I would say at least at a baseline, a DEXA should be done, and then maybe every 2 years should be considered. And if they have additional risk factors for osteoporosis, maybe this needs to be considered at a more frequent basis, but no earlier than 1 year from any study.
Excellent. Thank you. Very concise. Dr. Shufelt, we had also a number of questions coming in about cardiac risks and heart disease. This specific constituent says they are 45 with a BRCA1 mutation. Her gyno-onco wants her to schedule risk-reducing surgery, but heart disease runs in her family. Will removing her ovaries at 45 increase her risk of heart disease?
Well, let's just say, regardless of removing your ovaries, having a premature cardiovascular disease risk in your family is an important risk factor that you need to take into consideration, whether you're removing your ovaries or not. So that's actually considered one of the 5 predominant risk factors for heart disease in women. There are some new risk factors for women. So when I say about risk factors, I think about high blood pressure, high cholesterol, diabetes, smoking, and then that premature cardiovascular disease risk. So we've seen in a lot of studies, and it's very reproducible, whether you get natural menopause under the age of 45 or surgical menopause under the age of 45, with removing your ovaries, regardless of BRCA status, these women are at a slight increased risk for cardiovascular disease. And in general, if you can go on hormone therapy through the natural time of menopause, if that's amenable to your risk profile, that's what the current guidelines do recommend. And that is also for your bone health as well. But if you can't, that doesn't mean that you're going to get cardiovascular disease. What I always say is get connected with a preventive cardiologist or have a really good, strong internist who's going to do annual evaluations of those risk factors that I just mentioned. And then I will state that there's novel risk factors and certain new risk factors that we're taking into consideration for heart disease, which includes things that happen during pregnancy as well, like gestational diabetes, or if you had high blood pressure during pregnancy. So those are also important and why it's good to get checked in with a cardiologist.
Excellent. Thank you for covering all of the bases for us there. This next question is a broad sweeping question, a question that may have been asked by someone who was not able to attend our earlier talks on hormone replacement. And I want to ask it of kind of the whole panel. So this specific constituent is a breast cancer survivor with triple negative breast cancer. She's had all of her risk reducing surgeries, and she's experiencing extreme symptoms of menopause, fatigue, joint pain, weight gain, negative libido downside. Should she consider hormone replacement? And if not, what else can she do for her symptoms? Dr. Steiner, I'm going to ask you first.
Okay, I'm unmuted. I think that is a really good question because you have to be careful about triple negatives because Dr. Domchek will probably address this better than I will, but as time goes on, sometimes disease recurs and it doesn't always look like the initial disease, and perhaps receptor status can change. So it's a big unknown. But I think that the triple negative breast cancers tend to recur early when they're going to recur, within the first 5 years, while other breast cancers might be later recurring. So you may have a better answer about the status of your disease. But like everything else, you have to weigh the risks and the benefits and the quality of life. And I will tell you, in my practice, I have a handful of patients with a history of triple negative breast cancer who in fact are on hormone therapy because the quality of life for them is really enhanced and they are willing to take whatever theoretic risk there is. This is a shared decision that we make not lightly, but involve the whole team of care providers, their oncologists, their surgeons, and certainly the patient weighs in the most heavily on this. But I think quality of life is extremely important and that we need to take that into account while we weigh other risk factors, because there's many risk factors we weigh when we evaluate people for starting hormone therapy in the first place, like their history of clot and history of cardiovascular risk and things like that. So we would globally evaluate someone. We would look at their risk if they had low risk or high risk of recurrent disease, how long it's been since their diagnosis, and how much we think it will affect their quality of life. It's not an easy answer.
So yeah, I can just jump in from the oncology perspective because I'm a medical oncologist. There is an additional problem, which probably has been stated at other sessions, which is there's this annoying black box warning label on all estrogen products about in patients with prior breast cancers. And that includes, by the way, topical estrogens. So this is always a problem for us because really we wish that particularly for topical estrogens, it was not on there. There were actually some studies done years ago which looked at giving hormone replacement therapy to women with a history of breast cancer. And they were stopped early because, not surprisingly, if you had hormone receptor positive breast cancer, there was an increased risk of recurrence. In the subset that had triple negative disease, we really didn't see anything, but the numbers were too small. So that's why, that's why this is a very careful discussion. So in my practice, I try to maximize the non-hormonal ways to combat menopausal symptoms, which I know Dr. Steiner could certainly talk much more about. And then if that really doesn't work, we have to acknowledge that if someone were still premenopausal, if I treated a woman with triple negative breast cancer and they got their menstrual periods back, I wouldn't shut their ovaries back off. So if you will, if I took the ovaries out just because there was an ovarian cancer risk associated with a gene mutation, why not consider giving estrogen back? This is a very pragmatic approach. So, but we're very careful. Non-hormonal strategies first, consideration of risk and benefits as described. But I think that we shouldn't consider it completely off the table. We need to be very individual.
Thank you. And I think you really hit something on the head there, which is, there's a lot of constituents that are worried about quality of life. They're worried about sexual health, things like vaginal dryness. Dr. Steiner, can you talk and speak to a little bit more and elaborate on those non-hormonal treatments for menopause side effects and symptoms?
I'd be happy to do that. So there's actually a non-hormonal product that is FDA approved for treating hot flashes and vasomotor symptoms, night sweats, all the same thing. And that's paroxetine in very low doses. Other SSRIs, SNRIs actually are very effective for treating hot flashes, but it's off-label. They just haven't asked for the FDA for approval for those indications. Each of the non-hormonal treatments can treat specific symptoms. We have for GSM or for vaginal dryness, vulvovaginal atrophy, we have over-the-counter lubricants and moisturizers, which can be very, very effective. They're not as effective for some women as using local hormone therapy, but they can be very effective. When we're talking about hot flashes, in addition to paroxetine, which is non-hormonal, there's other medications that are FDA approved, but they'd be off-label, like gabapentin, which is great for women who have night sweats, because it helps them sleep and it gets rid of their night sweats. But again, it would be off-label. There's ditropan, which we use for overactive bladder, but in various doses, it's been studied, and with some side effects, it can help hot flashes as well. There's some new medications that are non-hormonal, which are coming down the pike. They're in phase 3 studies now, and they actually affect the receptors on the nerves in your brain that control your temperature. These are neurokinin 3 antagonists. And I think that, well, hopefully they'll be FDA approved at some point, so we can use those things. But lifestyle modifications can be very effective for some of the symptoms of menopause. Giving up caffeine, giving up alcohol for some women makes a huge difference. Layering clothing, having a fan on at night. There's just things that you can do to change your life, which also can help. And I'm sure there's many more non-hormonal things we can do. Cognitive behavioral therapy has been shown to be effective. There's a lot of different approaches.
Excellent, thank you. And I'm actually going to transition over to you, Dr. Khan, because we do have a constituent here who has developed osteoporosis, and she is asking questions about lifestyle changes, ways to integrate more calcium into her diet, supplements that she can take. What are your recommendations there?
So the general preventive measures that we recommend are I'm referring for physical therapy, for fall prevention. Now, these are younger women, so I mean, fall risk is probably going to be very low. We will also talk about calcium and vitamin D here. So the general guidance is to go with the recommendations from Institute of Medicine, which is for all postmenopausal women, a calcium intake of about 1,200 milligrams daily, and a vitamin D level of between 800 to 1,000 units for maintenance of vitamin D. Yes, we're seeing a lot of vitamin D deficiency, insufficiency in the population, so that has to be repleted with higher doses of vitamin D. And then for maintenance of 800 to 1,000 units of vitamin D can be prescribed. Now, we also need to keep in mind for osteoporosis, these are all preventive measures. They should not be considered as treatments. they should certainly be in adjunct to the medications that are currently FDA approved for osteoporosis. And so that would be a separate talk, talking about what's currently approved, and taking into consideration the age for these patients, their risk for breast cancer, and other. I think this has to be a talk that has to be done in collaboration with the other providers as well.
Thank you. Dr. Shufelt, we have this constituent who has come through. She just went through medically induced menopause. Her symptoms are severe, and she's wondering, what is the specific timeline for how long the severity of her symptoms will last? When will they start to decline? And about what does that timeline look like, if you could provide one?
Yeah, this is the $50 million question. So, and I wish I had a correct answer in terms of everyone's different. So symptoms can last on average anywhere from 2 to 7 years, but we do see studies out of Europe that follow women for much longer and know that there's a smaller percentage of women that can continue to have symptoms ongoing. So that's why it's important to talk to your doctor and really get an evaluation, because the non-hormonal options are good and they do work. And this is about quality of life and not really suffering in silence.
Excellent, thank you. And so to transition from non-hormonal options to hormonal options, Dr. Steiner and Dr. Domchek, for women who have had risk-reducing surgeries without cancer, can you speak to how effective hormonal treatments are and what are the risks associated with them going into later life to develop cancer going forward?
I'll take the risk part, and then I'll let Dr. Steiner take the effectiveness part. We do not have any randomized control trials of women who've had their ovaries out and didn't take hormone replacement therapy, or those who took their ovaries out and did. And part of this is because, as we've heard, different women experience this very differently. So some women have their ovaries out and have no symptoms at all, or have their ovaries out at, say, 48 and they don't feel a need to take hormone replacement therapy. And others have their ovaries out at 35 and are just so symptomatic that they're going to take hormone replacement therapy. So, in medicine, we like those gold standard randomized controlled trials to prove that there's not increased risk. We also have to take into account, if someone's had a risk-reducing mastectomy, her residual lifetime risk of breast cancer is 1 to 2%. So even if hormone replacement therapy, significantly increase the risk of breast cancer, which I'll get to in a minute, like the risk is already so small. But I look at this again, I'm sort of a pragmatic person, and women make estrogen until they're 50. If we take a women's ovaries out at 35 and give a little bit back, we're already giving less estrogen than we ever would. And so I really do think that although, and the data that we have, it's a little bit controversial, I admit, but the data that we've had is that when you take your ovaries out, you likely decrease your risk of breast cancer. Again, some studies have said yes, some studies have said no, but in no situation have we seen that taking hormone replacement therapy back after that, that increases risk more than where you started. So long story short, I hope that wasn't confusing. Long story short, from my perspective, in women who have not had breast cancer, I absolutely think that it's reasonable to give hormone replacement therapy back after risk-reducing salpingo oophorectomy.
I think the question here is, if you already have an increased risk of breast cancer because of your genetic status, how much more does taking estrogen increase that risk over what it is because of your genetic status if you haven't had prophylactic mastectomy and you're a pre-vivor? And Dr. Domchek has studied this, and if in the first couple of years, it doesn't look like in BRCA1 carriers, there's an increased risk of breast cancer, whether they're on estrogen alone. And this is after prophylactic oophorectomy. There isn't an increased risk of breast cancer, whether you're on estrogen or estrogen plus progesterone. Now, in the Women's Health Initiative, which was not looking at women who were at an increased risk of breast cancer, over time, 3 to 5 years use of combination therapy of estrogen plus progestin did increase the risk of invasive breast cancer, while women who were on estrogen alone actually had a lower risk of breast cancer than the women who didn't even take estrogen. And there was a little bit better survival among those women over 18 years of following them up. But the numbers here of increased risk of breast cancer are really very, very small. And certainly if you're a genetic carrier, that increases your risk of breast cancer more, in my estimation, than adding estrogen into the mix. So I think we really have to go for quality of life here, both in terms of day-to-day quality of life, but in terms of preventing these long-term comorbidities that occur with estrogen deprivation at a young age. And I think the long haul is keeping our eye on the prize.
Excellent. Well, thank you. This has been a little bit of a shorter panel for us, but we do have all of the questions that have come in from all of our attendees and constituents. And what we will do is our best to follow them up on the back end and post an FAQ with some answers for all of you here today. I'd like to take this time just to thank our panelists for joining us today, a very esteemed panel. We are so lucky to have you with us and in our FORCE community. And again, to our sponsors for bringing this programming to you. Thank you all for attending and continue to attend the rest of the sessions today.